Hi everyone, welcome to the Med Micro workshop. How I'm going to structure this. First, I would encourage you, if you haven't yet, take a few minutes to read the chapters on PID and vulvovaginal disease in your gynae lecture notes book. They're short chapters, it'll just take you a few minutes, and I think if you read them first, you'll benefit more from this workshop. After that, we are going to go through a couple of slides on syndromic management of various conditions. And then once we've gone through the syndromic management, we will spend some time, most of the time, going through different cases to reinforce your knowledge on the topic. I hope you enjoy it. To manage genital infections well, you'll need to follow the normal steps of taking a history, doing a thorough physical examination, and then making a diagnosis. Sometimes you can't just clinically figure out what specific organism is involved. And in that case, you're going to just identify the syndrome. Treatment involves either treating a specific organism if you're sure of it, or if you're not sure, you use a syndromic approach and you treat the syndrome generally. Health education is so important. That includes about condoms, about family planning, HIV counseling and testing, and syphilis testing if you think it's relevant. And partner notification and treatment is so important in a lot of these cases. An unusual vaginal discharge is a discharge that smells bad, that is an unusual color, so yellow or green, or is associated with other symptoms like itching or pain. Please note that there is quite a wide variety of normal discharges. They can be white, clear, cream, or even yellowish, but they don't smell bad and they're not associated with any other symptoms. You'll notice that there's a lot of overlap in the organisms that cause male urethritis syndrome, vaginal discharge syndrome, and lower abdominal pain in females. Gonorrhea and chlamydia can cause all of those conditions. And then for vaginal discharge syndrome, trichomonas and candida can also cause vaginal discharge syndrome. So there are extra antibiotics and antifungals that are used for treating vaginal discharge syndrome. Some genital ulcers can be associated with buboes, which are when a groin lymph node becomes infected and filled with pus. It becomes inflamed, it's red, and on examination you'll find that the area is fluctuant. Here's a flow chart for treating vaginal discharge syndrome. So you can see the flow chart begins with the patient complaining of abnormal vaginal discharge. Then you need to assess if the age is less than 35 or the partner has urethritis syndrome. Now, of course, I think the problem with this flow chart is that the patient won't always know if her partner has male urethritis syndrome. So I think you can also look at the risk factors, the sexual risk factors of the woman, and make a clinical decision. If the woman is not sexually active, then I think you can carry on with the treatment for vaginal candida or bacterial vaginosis. And otherwise, if you think that there are risk factors for an STI, or actually if you're in doubt at all, then rather treat it with syndromic management as if it is an STI, because the consequences of gonorrhea or chlamydia long-term are quite severe. Ceftriaxone is a third-generation cephalosporin, which inhibits bacteria cell wall synthesis. It's one of the treatments for vaginal discharge syndrome, and it targets Neisseria gonorrhea. The disadvantage is that there is no pill that you can take, but it can be used as a stat IM injection in these patients. It is appropriate to use in patients who have very mild penicillin hypersensitivity, but not if they've got anaphylaxis or any features like bronchospasm or angioedema. Azithromycin is a macrolide, which is also part of the management of vaginal discharge syndrome. It treats chlamydia trachomatis. Previously, we used to use doxycycline for treating chlamydia, but the problem with doxycycline is it was quite a long course. They had to take it for at least 1 week and sometimes 2 weeks. With azithromycin, because it has a prolonged elimination, giving a single dose is equivalent to a week of doxycycline. So it's wonderful for patient compliance. Metronidazole works by inhibiting nucleic acid synthesis. It can be taken orally and IV. The major disadvantage is that it causes nausea, and it treats bacterial vaginosis and trichomonas. Clotrimazole is an antifungal which alters the cell membranes of the yeasts, which stops them from growing. It treats candida and all different types of candida, so it's the treatment for vaginal candidiasis. It can also be bought over the counter.
Yeah, doc, so I've got this pain. It's down here, like right underneath here. And I'm also I'm bleeding when it's not my period. Like it comes out like little spots, that's abnormal. It's been like that for about 2 weeks. And I must say that it's a little bit blind, but my discharge is sort of normal, but it's sometimes a bit yellow, and then sometimes it just doesn't smell so good. So that's like a bit awkward. You say, well, am I sexually active? You ask. Yeah, my boyfriend and I have been going steady for 3 months. We met at gym about 6 months ago. So yeah, we're together. Sorry, do we use condoms? Sometimes, but not always, because I'm on the pill. It's that what's it called now? Nordet. Yeah, that's the one I'm on. So yeah, that's the situation I'm sitting with.
For you to benefit most from this workshop, I suggest you get a pen and paper and try to answer these questions yourself before you look at the answers. Please present the patient.
This is Brooklyn. She's 22 years old. Very, very hot when her temperature was very high when she came in. Lots of pain. She said she can't even walk at all. She's got normal periods, no discharge, and I think it's very important. Her boyfriend sometimes removes the condom, so she's using the copper T now. When I examined her, every time I touch her, she screams. Touch her abdomen, she screams. Every time. I did the speculum, the cervix, it looks normal. The strings are there. Bimanual palpation, touch the cervix. She screams every time. Touch it, scream. It feels quite full on the left, and that was what I found.
Doctor, this is so awkward. I'm convinced I have an STI. I've got this discharge, which is so itchy. I want to die. I've been scratching myself so much. And the discharge is really gross. It looks like cottage cheese. And the worst part is, I never thought my girlfriend would cheat on me. And now I have an STI.
Hi, Doc. I'm Dana. I'm 21 years old, and I'm pregnant. Yay! 10 weeks and 3 days. But I'm here because I've got a little problem. I've got this discharge, which is very watery. My panties are so wet, and my boyfriend, after we, he said to me, Dana, you smell like a codfish. A codfish.
I'm Esther. I really hope you can help me. You see, Doctor, I've been struggling with this for a very long time, and well, you see, I've got these horrible warts, and they're everywhere. They're all around my vagina and around my bottom. It's so horrible. I can't bear for my husband to see me. He wants to have a baby, but I don't want him to even see me naked, let alone have sex. I've got HIV. I'm on treatment. I usually take it, except I struggle on work days. And on the weekends you often forget.
Mom, sleeping.
Hi everyone, I'm going to show you how to marsupialize a Bartholin's abscess. So what you'll need is local anesthetic. Ideally you would do it under general anesthetic, but often we don't have that option. An absorbable suture material like Vicryl 2.0 and a normal stitch pack with a needle holder, scissors, a scalpel. That's really all you'll need. I'm going to be using tweezers, an upholstery needle with some cotton thread and kitchen scissors. So before you start, you'll need to clean the area and anesthetize liberally. Here's our patient. So I'm going to start by cutting an X shape in this Bartholin's abscess. You can see this is a really bad one. It's the stripy kind. They're the worst. So I'm just going to lift this up, and you can use a scalpel for this, but scissors work better when you've got a cotton woman. So I'm going to cut across like that in an X shape and just extend it a little bit on the side. And I'm going to just widen it a little bit. Oh, and there's so much pus coming out. Wow. There we go. I'm just going to get all that pus out. And I'm just making an X shape here. There we are. Now I'm going to just take each one of these little flaps and suture it back onto the tissue around it. There we go. So this is why it's really important to apply your local anesthetic quite liberally around the abscess itself, because this tissue is going to be really sore. There we go, that's one down, 4 to go, 3 to go. So I'm just going to stitch this back. Okay, the proportions are not quite right in this lady. It shouldn't normally go to the inner thigh, but it is in this case. Here we are. Two. It's quite quick, we're nearly finished. One more over here. So the whole point of this is to keep the wound open so that pus can drain out freely, so that it won't reaccumulate and cause another abscess. There we go, that's finished, it's marsupialized. Now all you need to do is pack the wound to keep it open, and she can go home. Hi Doc, I'm Helen. I'm 18 years old and I'm in my first year of university, and I've decided this year that I'm going to just really express myself and have lots of sex. So I've been having a lot of sex and it's been going wonderfully, but now I think from all the friction there's a painful spot. It's a little bit raw looking outside of my vagina. I think it's from the friction. Oh, no, I don't have a discharge. No. And don't worry, I've been on the injection since I was 16, so that's sorted. No babies. I don't like condoms. I don't want to make the friction worse. I don't want the friction to be worse. No, I haven't tested for HIV. I think I'm fine. All of the men have been totally healthy, so I'm not going to worry about HIV.